Let's discuss extremely high-yield infectious disease topics and go through some questions that will increase your score on exam day. What is the typical empiric treatment for patients with human bite wounds? Augmentin. Human bite wounds are typically polymicrobial with both anaerobic and aerobic organisms. It's also important to note that these wounds are typically left open to drain and heal by secondary intention because there is a higher risk of infection with closure of the wound. What is the likely causative microorganism in an alcoholic sailor that develops high-grade fever hours after cutting his foot while sailing in the ocean? The cut is surrounded by erythema and dark-colored bullae, with streaking erythema extending proximally up the limb. Vibrio vulnificus. So this is found in marine environments and causes severe disease. For example, patients can present with rapidly progressive septicemia or even necrotizing fasciitis. Being infected with this microorganism is especially common in patients with liver disease. What are the two most common causes of secondary bacterial pneumonia? Strep pneumoniae and Staph aureus. So, patients with secondary bacterial pneumonia typically present with worsening fever and pulmonary symptoms after initial symptomatic improvement. What is the likely diagnosis in a patient with recently diagnosed infective endocarditis that now presents with fever and left-sided chest or abdominal pain? CT reveals a left-sided pleural effusion and splenomegaly with a splenic fluid collection. So, the most likely diagnosis is a splenic abscess secondary to infective endocarditis. So, splenic abscesses usually presents with a triad of fever, leukocytosis, and left upper quadrant abdominal pain. And treatment is with antibiotics plus a splenectomy. Which heart valve is most frequently involved in bacterial endocarditis? The mitral valve. Which heart valve is most frequently involved in bacterial endocarditis in IV drug users? The tricuspid valve. And recall that this is associated with organisms such as Staph aureus, Pseudomonas, and Candida. What is the most common symptom of bacterial endocarditis? Fever. So you can recall the signs or symptoms of bacterial endocarditis with mnemonic from Jane. F, fever. R, Roth spots. O, Osler nodes. M, murmur. J, Janeway lesions. A, anemia. N, nail bed hemorrhages. E, emboli. What is the likely diagnosis in an afebrile farmer with right upper quadrant pain and a smooth, round hepatic cyst with septations and eggshell calcifications on ultrasound? Echinococcus granulosus infection. So recall that this is a cystode, and patients with this infection can present with a lack of fever and cystic lesions. However, for an infection with Entamoeba histolytica, These patients would be febrile with a smooth cystic subcapsular mass. What is the likely result of the following serologic tests in a patient vaccinated against hepatitis B? So the question is basically asking, if a patient is vaccinated against hepatitis B, what changes would you see in the hepatitis surface antigen, the hepatitis surface antibody, and the hepatitis C or core antibody? So in vaccinated patients, the surface antigen would be negative, the surface antibody would be positive, and the core antibody would be negative. How I remember this concept is that for persons that are immune due to immunization, they have the antibodies which would be positive. So those positive antibodies make you anti-sick. You can't get sick because you're vaccinated or immunized against hepatitis B. So that's one way to remember this fact. What is the likely result of the following serologic test in a patient naturally immunized against hepatitis B? Well, the hepatitis surface antigen is negative, hepatitis surface antibody is positive, and the hepatitis core antibody is also positive. So, how you can remember this is when you see that the core antibody is positive, this means that the patient has come across hepatitis B. So, a positive core antibody means that the patient has come across hepatitis. So, that's either a previous or ongoing infection. And as previously discussed, when the surface antibody is positive, then you are anti-sick. So you can't really get sick from it. So those two things are positive when you are naturally immune to hepatitis. So it's very important that you know the difference between the test results for when a patient has received a vaccine against hepatitis B versus natural immunization against hepatitis B. So you can just rewind that and play that again to just really emphasize this fact. What is the likely result of the following serologic tests in a patient with chronic hepatitis B? So the surface antigen is positive, the surface antibody is negative, and the core antibody is positive. So let's break this down. So in chronic hepatitis B, it makes sense that the core antibody would be positive because remember, a positive core antibody means that you have come across hepatitis B. So whether that is a previous or ongoing infection. So that would of course be positive in chronic hepatitis B. If your hepatitis surface antigen is positive, that means that you are sick with Hep B. That can be either an acute or chronic infection. So, hepatitis surface antigen means that you're sick with Hep B, so that will be positive in a patient with chronic hepatitis B. What antibody is typically positive during the window phase of hepatitis B infection? IgM anti-HBC. Infants born to mothers with active hepatitis B should be managed with what? Well, first, they need the hepatitis B vaccine and the immunoglobulin at birth. After they receive these two, then they can go on to get their routine hepatitis B vaccines at 2 and 6 months. It's very important that you check serologies 3 months after the third dose of the vaccine. So that's around 9 months to see if the infant is infected with hepatitis or not. What is post exposure prophylaxis for hepatitis B exposure? So, if you are non immune, then you need to give immunoglobulin and the vaccine. However, if you are immune, then don't give anything at all. So, non immune means that they are unvaccinated or have an incomplete response to initial vaccination. So, you give the immunoglobulin for immediate protection, while the vaccine is also given, but this takes time to build the response. What is the likely causative organism in a male that presents with dysuria, urinary frequency, and mucopurulent discharge? Gram stain and urine culture are negative. Chlamydia. So recall that the gram stain shows gram-negative cocci in 95% of cases of gonococcal arthritis. What is the likely diagnosis in a sex worker that presents with fever, chills, polyarthralgia, and pustules on the chest and extensor surfaces of the forearms? Disseminated gonococcal infection. How is the diagnosis of mucormycosis established? Sinus endoscopy with biopsy and culture. What is the likely diagnosis in a young patient that presents with 2 days of fever, altered mental status, seizures, and the lumbar puncture findings below? So the opening pressure is normal, protein is also normal, red blood cells and white blood cells are high, and there is a lymphocyte predominance, so there's 90%. The most likely diagnosis is viral encephalitis, for example, due to HSV. What type of catheterization is recommended for patients with a neurogenic bladder to reduce the risk of catheter associated UTI? Clean intermittent catheterization. This refers to the insertion and removal of a clean urinary catheter every 4 to 6 hours, and this can be performed by the patient or a caregiver. What is the likely causative organism in a patient that develops osteomyelitis after stepping on a rusty nail? The nail pierces the patient's shoes and pierces the heel. Pseudomonas. So, Staph aureus and Pseudomonas are responsible for most deep infections following puncture wounds. The sole of a shoe, though, is very warm and moist and is a hospitable environment for Pseudomonas. So that's why Pseudomonas is more likely than Staph aureus in this specific scenario. What is the recommended treatment for Legionnaire's disease? Macrolides or respiratory fluoroquinolones such as levofloxacin and moxifloxacin. What is the next step in management for a patient being treated with ripe therapy for TB for the past month that develops mild elevations in AST and ALT. Continue with current treatment and monitor the LFTs. Subclinical hepatotoxicity is common within the first few weeks of isoniazid therapy. It is typically self-limited and resolves without intervention. So, significant hepatotoxicity, however, warrants switching treatment regimens. What is the next step in management for a patient with suspected ventilator associated pneumonia with a chest x ray demonstrating lobar infiltrates? Gram stain and culture of respiratory secretions. So, this should be obtained prior to administering empiric antibiotics. What is the likely diagnosis in an HIV patient with a CD4 count of 25 that presents with 3 weeks of fever, night sweats, abdominal pain, diarrhea, and weight loss? Chest x ray, CMV serology, and PPD are all negative. Disseminated Mycobacterium avium complex or MAC infection. So, TB and CMV are less likely due to the fact that they have a normal chest x ray and also that the CMV serology is negative. What is the next step in management for a patient with HIV and a CD4 count of 85 that presents with dysphagia and substernal burning? White plaques that are easily removable are present on the palate. Oral fluconazole. So, if symptoms don't improve with this medication, then endoscopy would be warranted. Let's take a closer look at how to interpret the serologic test for hepatitis B because this is extremely high yield and it can be a bit confusing. So, we need to think about the antigens and the antibodies for Hep B because they mean completely different things. Let's first focus on the antigens. When you think about the antigens, I want you to think of this phrase. Antigens, they make you sick and easily spread the disease. Antigens make you sick and easily spread the disease. So the hepatitis B surface antigen, that means that you are sick with Hep B. This sickness could be either due to acute or chronic hepatitis B infection. Hepatitis B E antigen means that you easily spread the disease. So, this antigen refers to the replication and transmissibility of hepatitis B. So, remember, when you think of antigens, think of the phrase that antigens make you sick and easily spread the disease. So, the surface antigen means that you're sick, whether acute or chronic, with hepatitis B. The E antigen means that you easily spread the disease. Okay, so just pause the video or take a screenshot and really commit this to memory. But now let's move on to the antibodies. So the antibodies are basically the opposite of the antigens. So the surface antibody means that you are anti-sick. You can't get sick from hepatitis B because you are immune from either receiving the vaccine or immune from recovery of a previous hepatitis B infection or exposure. The E antibody means that you're anti-easily spread. So you don't easily spread hepatitis B. There's low transmissibility. However, for the core antibody, that means that you have come across hepatitis B before. So this could be due to a acute infection. If there's an acute infection, then what you'll see is a positive IgM hepatitis B core antibody. However, if it's a chronic infection, you'll see a positive IgG hepatitis B core antibody. So the surface antibody is anti-sick. You are immune either from receiving the vaccine or recovery from a previous infection. Hepatitis E antibody, that means you're anti-easily spread. There's a low transmissibility. The core antibody means that you have come across hepatitis B before, whether that's an acute or chronic infection. Okay, now that that's broken down a bit more easily, let's do 3 practice questions. 2 of them you've seen before, but one of them is completely new. So let's go through this together. The question asks, what is the likely result of the following serologic tests in a patient vaccinated against hepatitis B? So this should look very familiar to you, but let's go through it together. So the hepatitis B surface antigen is negative. Remember that the surface antigen means that you are sick with Hep B. But the fact that it's negative means that there's no active infection. The hepatitis surface antibody is the opposite of the antigen, and it is positive. So remember that the hepatitis surface antibody is anti-sick. So the fact that it is positive means that this patient is immune from either recovery from a previous infection or by receiving the vaccine. The hepatitis B core antibody is negative. So the hepatitis B core antibody means that you have come across hepatitis B before. So this could be either an acute or chronic infection, but it's negative. So that means that there is no previous or ongoing infection. So to sum it all up, in a patient that is vaccinated against hepatitis B, you would expect to see a positive hepatitis B surface antibody because that is anti-sick, and that means that you are immune from either the vaccine or recovery. Okay, great. Now let's move on to question number 2 of this short practice test series. What is the likely result of the following serologic tests in a patient naturally immunized against hepatitis B? Again, this one should look a bit familiar to you. So the hepatitis B surface antigen is negative. So remember that hepatitis B surface antigen means that you are sick with hepatitis B, but it's negative in this patient, so there is no active infection. The hepatitis B surface antibody is positive. Remember that the hepatitis B surface antibody means anti-sick. It's the opposite of the antigen. So the fact that it is positive means that this patient is immune from either receiving the vaccine or recovery. The hepatitis B core antibody is also positive. The hepatitis B core antibody means that the patient has come across hepatitis B. This could be either an acute or chronic infection. So the fact that it's positive means that the patient had a previous infection. So in a patient that is naturally immunized against hepatitis B, you would see positive hepatitis B surface antibodies, means that they're anti-sick, so they have some sort of immunity going on. And the hepatitis B core antibody would also be positive because that's referring to the previous infection that they had that made them naturally immunized right now. Now let's move on to the brand new question. What is the likely cause of the following serologic test results? So right here we have the hepatitis B surface antigen, which is positive. So remember, this refers to the patient being sick with Hep B. So yes, they have an active infection going on here. Hepatitis B surface antibody is negative. So that means that they are anti-sick. They do not have any immunity from the vaccine or from previous recovery. The hepatitis B core antibody is positive. Remember that this core antibody means that the patient has come across Hep B before. So yes, this patient has had a previous infection or an ongoing infection. Also, very important, the IgM anti-HBC is also positive. And this means that the patient has an acute ongoing infection. So, when we take a closer look at this, we can see that the surface antigen is positive. So they have an active infection. The core antibody is also positive, meaning that they have a previous or ongoing infection. But we also see that the IgM anti-HBC is positive. Remember, IgM acute, IgG chronic, IgM acute, IgG chronic. So the most likely cause of these serologic results is that this patient has an acute hepatitis B infection. What is the likely diagnosis in a hemodynamically unstable patient that presents with fever, vomiting, and a diffuse confluent macular papular rash on the trunk and extremities? The patient recently had anterior packing in the emergency department for a nosebleed. Toxic shock syndrome. And the organism most commonly involved is Staph aureus. And patients can develop toxic shock syndrome if they did not remove a tampon, if they did not remove nasal packing. So you can see cases like this, especially when you're preparing for step 3, the CCS cases. So think about toxic shock syndrome if a patient presents with these symptoms and signs. What is the likely diagnosis in a patient with a recent UTI that presents with fever, back pain, focal tenderness over the L4 to L5 vertebrae, and paravertebral muscle spasm? Vertebral osteomyelitis. So this can present in patients that have a hematogenous spread of a UTI. And initial workup includes doing a CBC, blood cultures, ESR, CRP, and plain spinal x-rays or MRI. So the MRI, of course, is more accurate than the x-ray, and it can be confirmed with a open or CT guided biopsy. What is the treatment of choice in a pregnant patient with syphilis who has a penicillin allergy? Intramuscular penicillin G, because the patient needs to be desensitized. Penicillin is the treatment of choice for syphilis even in pregnancy, regardless of drug allergies. So remember that there are two types of penicillin. Iron penicillin, you can have penicillin G and penicillin V. So how you can remember which is which is by saying hit the G for the STD. A patient presents with recurrent UTIs more than 3 months with transient improvement with antibiotics and painful ejaculation. Urine culture shows bacteriuria. What is the diagnosis and treatment? So the diagnosis would be chronic bacterial prostatitis, and you treat with 6 weeks of a fluoroquinolone or TMP SMX. So, chronic bacterial prostatitis is usually due to E. coli going via the urethra to the prostate, and diagnosis requires a urinalysis before and after a prostatic massage. This urinalysis would reveal urine leukocytosis or bacteriuria. If there's a negative urine culture, it is chronic prostatitis or chronic pelvic pain syndrome. What is the likely diagnosis in an immunocompromised patient with fever, pleuritic chest pain, cough with hemoptysis, and CT showing cavitary nodules with surrounding ground glass opacities on CT? Invasive aspergillosis. What is the treatment of choice of invasive aspergillosis? IV voriconazole. What is the recommended treatment for patients with cryptococcal meningoencephalitis? Amphotericin B plus flucytosine. So you typically give them these two medications for more than 2 weeks and until asymptomatic and you get a negative CSF. After you reach these parameters, you want to follow up by giving fluconazole for more than a year. Which organism can cause profuse water diarrhea due to germination of spores? Clostridioides. So recall that this organism is a spore-forming gram-negative anaerobic bacteria that releases exotoxins A and B. It's also transmitted via the fecal-oral route. What is the treatment of choice of croup? So if it's mild, you want to give a cool mist and steroids. If it's moderate, meaning that there is stridor at rest, then give steroids and nebulize racemic epinephrine. What pathogens most commonly cause croup and epiglottitis? Croup is most commonly caused by parainfluenza virus, while epiglottitis is most commonly caused by H. influenzae. Of course, this is rapidly changing because of the Hib vaccine. There are other organisms that can cause this condition. If you know them, then leave them in the comment section below. What is the treatment of choice of pyelonephritis in pregnant patients? Well, you can use drugs such as cephalexin and fosfomycin. But what's very, very important is that you do not use fluoroquinolones to treat pyelonephritis in pregnant patients. Recall that fluoroquinolones have teratogenic effects and can cause damage or deformation of cartilage. What is the treatment of choice of uncomplicated outpatient pyelonephritis and uncomplicated inpatient pyelonephritis? For uncomplicated outpatient pyelonephritis, you can give oral fluoroquinolone such as ciprofloxacin. However, for uncomplicated inpatient pyelonephritis, you want to give ceftriaxone. When is breastfeeding contraindicated? Active tuberculosis, maternal HIV infection, herpetic breast lesions, active varicella infection, chemotherapy or radiation therapy, active alcohol use, galactosemia. So, as you can tell with this list, most of these are maternal contraindications, like things that are going on with the mom that would cause him not to be able to breastfeed or recommended not to breastfeed at this time. However, the only one that is an infant or neonate contraindication is galactosemia, so that's very high yield to note. What is the recommended treatment for confirmed gonorrhea infection? Single dose azithromycin and IM ceftriaxone. What condition can a positive tourniquet test indicate? Dengue fever. So this is associated with a positive tourniquet test, which results in petechiae after blood pressure cuff inflation. What is the best prognostic marker for primary CNS lymphoma? Degree of immunosuppression or CD4 count. What is the next step in management for a patient found to have positive HCV antibodies? HCV RNA testing. So, hepatitis C antibodies are positive in the acute and chronic phases of the infection, previous Hep C infection, or simply false positive. So, we need to confirm the PCR testing of RNA. So basically, to diagnose Hep C, you need both positive serology and a positive HCV RNA levels. What prophylactic medications should be initiated in a patient who is beginning high dose immunosuppression therapy following a renal transplant? Trimethoprim for PCP and ganciclovir or valganciclovir for CMV. How would you treat these conditions? Uncomplicated outpatient treatment of community-acquired pneumonia and uncomplicated inpatient treatment of community-acquired pneumonia. Like, which antibiotics would you give these patients? Well, for uncomplicated outpatient treatment of community-acquired pneumonia, you give amoxicillin or doxycycline. For uncomplicated inpatient treatment of CAP, you can give ceftriaxone and a macrolide such as azithromycin or fluoroquinolone monotherapy. So if you're preparing for USMLE Step 3 exams, concepts like these are extremely high yield because examiners expect you to somehow confuse the different medications used based on if the pneumonia is complicated or uncomplicated or if it's treated inpatient or outpatient. So very important to take a note of this. What is the treatment of choice of strep throat? A 10-day course of penicillin, amoxicillin, which prevents acute rheumatic fever. So treating group A strep pharyngitis does prevent rheumatic fever. However, it does not prevent post-strep glomerulonephritis. It basically prevents the worst one, which is rheumatic fever. Echinella is a gram-negative anaerobe commonly found in what situation or when would patients be infected with this organism? Human bites. So human bites in general are polymicrobial in nature. You can be infected with organisms such as viridians, Staph aureus, and various anaerobes when you're bitten by a human. However, if you see that the patient is infected with an organism such as Pastorella, then you want to consider a cat or dog bite. So this isn't a question, but a high yield learning point that I want you to commit to memory. And that's the fact that rhinosinusitis is most commonly caused by viral organisms, so it does not require treatment with antibiotics. However, you should consider antibiotic treatment if any one or more of these are seen, and that includes symptoms lasting greater than 10 days without improvement. Symptoms are severe, for example, fever greater than 102, purulent mucus, or facial pain for more than 3 days. Also, if the viral upper respiratory tract symptoms worsen after initial improvement. So if you see any one of these things, the likely diagnosis is acute bacterial rhinosinusitis, which is treated with oral antibiotics such as amoxicillin. It's also high yield to note that patients with rhinosinusitis do not require additional imaging unless there's signs of extension into the central nervous system or orbit. What is the treatment of choice of acute bacterial rhinosinusitis? Oral antibiotics. So if you're just paying attention to my mini lecture on rhinosinusitis, then you most definitely already knew the answer to this, but let's move on. What is the treatment of choice of a breastfeeding patient with Trichomonas vaginalis? A single dose of oral metronidazole, 2 milligrams, and then you want to discard the breast milk for 24 hours after you gave the patient this medication. So metronidazole can enter breast milk, causing loose stools and candidiasis in exposed infants. Also, it's high yield that, just like for any other Trichomonas vaginalis infection, whether pregnant or not, you always want to treat the partner. What is the next best step in a patient with ongoing dysuria despite giving azithromycin for non-gonococcal urethritis? Repeat urethral fluid gram stain. So there are other organisms that can cause non-gonococcal urethritis that are not responsive to azithromycin. What is the most likely diagnosis in an immigrant from Africa who develops cystitis with symptoms of dysuria and urinary frequency and terminal hematuria and peripheral eosinophilia? Urinary schistosomiasis. So this condition has the greatest prevalence in Africa and is diagnosed with urine sediment microscopy, which identifies the eggs. Once you confirm diagnosis, you want to treat with praziquantel.